Good afternoon, everyone, and welcome to this session Reimagining Medical Education in the 21st Century. My name is Sachin, and I am working as an Associate Director Client Relations with QS Gauge. This roundtable is part of the series of roundtables that we are doing on different specific subject areas. And in that series, today we are going to talk about medical education. So, education, as we understand, has gone through tremendous changes in the 21st century, be it the changes in the needs and expectations of the society, or the corporate world and the students, or the use of technology, which is all pervasive. And the recent pandemic, which has also impacted education sector heavily. And then, as a result of all of this, the need on institutions side to adapt themselves to these changing scenarios, and medical education is no different, and that has also been impacted and also experiencing similar sort of changes. So today we'll try to understand more about these aspects from the perspective of medical education, and we have three eminent panelists for that. So, without much ado, I like to invite all of them on this platform and to share their valuable thoughts with us. So, our first panelist for today is Dr. Ashok Kumar Mahapatra. He's the Vice Chancellor of Anusandhan University, and he is also the ex Chief of Neurosciences Center and Dean Research, AIMS New Delhi, and former Director, AIMS Bhubaneswar, which was from 2012 to 2016. Dr. Mahapatra is an eminent neurosurgeon, completed his MBBS in 1975 from MKCG College, and then his Master of Surgery from AIMS in 1979, and then postdoc from AIMS in 1982. So welcome, Dr. Mahapatra. We are looking forward to listening your views on this subject. Our next panelist for today is Dr. Medha Rao. She is the principal and dean, Ramaya Medical College and Hospitals. She is an MBBS, an MD, and PGD HHM, and has over 37 years of experience in teaching and consulting. So, welcome, Dr. Rao. We are looking forward to listening your views on this very topic as well. Our third panelist is Professor S. Raisuddin. He is the advisor, research, and director, internal quality assurance cell at Jamia Hamdard, uh, deemed to be university. Dr. Raisuddin is an academician, academic administrator, and active researcher with a track record of over 25 years. So, welcome, Professor Raisuddin. Welcome to this event, and thanks for taking out time for this session. So, without much delay, and as I tried my best to set the context as far as the changes in education sector are concerned, I like to first go to Dr. Rao, as ma'am, you have a very long and a very strong experience of 37 years in this specific segment. So, how do you see it changing in the period of last 10, 15, 20 years, particularly 21st century, if we talk about both from the changes which are being taken place in the society, plus how the educational institutions have coped up with those challenges, or rather changes that I would say. So, your views on this, ma'am.
At the outset, let me thank the organizers for inviting us and giving us this golden opportunity of sharing our experiences. And thank you so much for that. Now, as you put up the question saying what it's been like now, coming from about 10 to 15 years of a medical education training program, but let me take the liberty of going even further behind, about 30 to 40 years back when I was an undergrad student. What happened was that was a landscape where there were two major aspects of medical training, and they constituted one was primarily diagnostic and the other was therapeutic. And under the cup of the diagnostics, about 70 to 80% was the emphasis on clinical examination, and the rest of it was a supportive investigative examination. What happened with that? The consequence was emphasis was laid on building a very profound, valuable rapport with the patient. The patients were heard out. Medicine was then described as what is called as art of medicine, and there was a lot of comprehensive care, and the patient was treated as a whole, and the person in the patient was more important than treating the patient as an objective. So that said, there were a lot of these soft skills which were inculcated strongly. And there was another thing which automatically took shape in the training was a lifelong learning. What happened then on gradually as technology developed? The scenario changed. The technology started developing at a very rapid speed in all sectors, diagnostics, therapeutics. Heavily investments were heavy on the R&D sections. And as these crept in, the landscape changed. There came an era of super specialization. There came an era of subspecialization. And what was the consequence? The fragmented approach began. When the fragmented approach began, and then the therapeutics started emphasizing on mastering of those clusters of diseases pertaining to a particular organ. And that's where the entire training had to be, it had to take a different turn, trying to train the undergraduates to organ specific evaluations. So that was one of the major turns sometime 15 years ago. Then there was an emphasis on medical emergencies, accident trauma, and tertiary care. So there used to be a primary care, a secondary care, and a tertiary care. A lot of prevention happened initially, although we kept training about preventive, curative, rehabilitative. For this reason, where commercialization, elements of commercialization were creeping in, primary care seemed to take the back seat. And when this happened, the medical education had its own toll because we were now facing with a scenario where a lot of these new things had to be brought in and included, not forgetting the primary care, not forgetting the basics of medicine, which essentially needed to be told. And when that happened, it took a heavy toll on the medical education system. That's when the standardized training was suffering and new things had to be started. So, as we stand today, we have a lot of technology in health. We have medical legal issues in health. We have commercialization coming into health sector. We have community care requirement coming into health sector. We have other policies and decision making at different levels in the health sector. And of course, I am not saying that the whole thing is a confused lot, but we are trying our best to be very, very discreet in imparting to the students the essentials of all the emerging aspects. We are focusing now on creating those abilities in the student to continue what is called as a very important aspect of training, the aspect of lifelong learning, self-learning, because that's a single way to keep up with what is developing at a very high speed. So keeping ourselves tuned with this was another challenge, where the faculty had to keep in tune with all the things which are developing. Added to that, research started gaining a lot of importance and has become a central, almost central and a pivotal role in any kind of profession, and medical education cannot escape from this. So when you come to a pointed question of research, where I'm sure the Professor Esudin will be a better person to say, but I can also tell you the kind of research, training in research, what it does to the student. I will tell you that when you come to that question. So going ahead, I would say that it's not very easy to predict what medical education training is going to be like looking ahead. Nevertheless, the new thing that has happened is there's going to be an emphasis on competency based. We are kind of coming back into the same thing. The circle is getting completed. The focus is now again changing on competency based, which I said was 75 to 80% of clinical medicine 30 years ago. And the diagnostics took up a large chunk to 60 to 70% in the middle phase. But now again, there's going to be an emphasis on the clinical teaching and then interpretation of the diagnostics, interpretation of the newer techniques needs something which is to be fine tuned because that ability being inculcated in the student is our present focus because we got to make them independent to learn the new things, to be able to use them judiciously and very carefully, and then develop the ability to interpret so that the entire outcome is patient centric. And this training has become much more complex. What with the societal which are increasing, the societal demands are increasing by the day. There are patients' rights which are in vogue. The patient and the family members are no more passive people who are going to receive from us. They are partners in decision making. And that brings us to what is again the accreditation processes, quality care, patient safety, and I would like to add a doctor safety as well. So that is the current scenario, and we are looking ahead to have a good matrix where we fill up the proper slots for what is critically important. So if I may draw a little summary there, it has to be a focused aspect of the training. Focus is on competency. Focus is on abilities to be inculcated as to ability to keep updated, ability to interpret, ability to use the updates judiciously and carefully, ability and develop the power of negotiation and explaining to the patient and the families as to what are the plans for the treatment, and a difficult ability to win the faith of the patient. That's where we are going to be serving the society as we are expected to serve the society. Does that answer your question, Mr. Sachin? Does that answer your question, Sachin?
So very interesting views, ma'am, from how the education is moving towards specializations and how technology is bringing both the aspects in it, be it the opportunities which are coming in terms of lifelong learning and developing the competencies and the abilities, and also the challenges which are coming along with it. So, may I now move to Dr. Mahapatra? As sir, you have been part of one of the best medical institute in the country, AIMS, for a very long time, and now you are the vice chancellor of a private university. So, what has been your observation in this regard, and especially when we talk about education per se? If we look at the segment, say AIMS is an old institute, is a very respected institute following best kind of practices, whereas how these changes and all the technologies are being implemented in private sector as well. And I would also request you to keep your views to not more than 3 to 4 minutes. If that's possible.
Good afternoon, Professor Rao, Professor Roisuddin, and Sachin. I think it's a very important question to see how the medical education in this country has changed. If you look at the year 1900, there are less than 5 medical colleges in the country. We are facing the large amount of challenge to deal with our health by 1947. By then, there are about less than 50 medical colleges. So we increased the medical colleges. When I joined MBBS 50 years back, there are about less than 120, 130. Now we have 500 medical colleges. Why I am telling that is very specific. We need 18 lakhs of doctors in this country, and last 75 years, we have produced 7.5 lakh doctors. And if you look at the doctor-patient ratio, the India is from lowest 170 out of 180 countries. We are not talking about quality of education. We are not talking about super specialization. If you go across India, you find half of the primary health center do not have doctors. So we have not produced doctor. In a given scenario, we have to produce, give healthcare, and now the COVID. For your information, we had 2,200 COVID beds, and in about a month back, in 15th of September, nobody was getting bed in Odisha for COVID patient. So now you have to understand. Then the question arises, if you post independence, we want to have number, quality, education, research, and patient care. That is the reason Board Commission told that we have to have more medical colleges, and AIMS was created in 1956 with purpose to have excellent medical care, world-class research, and education of the international standard. So there are three parts of our medical education, that is good doctors, good quality doctors, skillful doctors, and research-oriented doctors. I joined AIMS in 75 and retired 2017 after 42 years and a half. The question is that what is the past 40 years we did between 1950? We want to develop medical colleges and build up the colleges. And it is absolutely right what Dr. Rao said, the two types of medical education. One is British side and one is American. British side is more clinical oriented, practically oriented. American medicine is safe medicine and investigation oriented. Today we are sandwiched between American type or British side. So what is happening? The medical education, which was skill based, experience based, and expert based, is now all investigation. I know people sitting in Bombay send a MRI and say, do I require an operation for a disc? There's a brain hemorrhage sitting somewhere in Delhi and sent to Bhubaneswar, I have brain hemorrhage, can I get operated? Operation is not decided on the CT scan or MR, it's a patient. I know patient flying from Bombay to Delhi for disc operation, which doctor never saw. Why this situation arise? This situation arise because there's a demand and supply. So what is we are doing? We have to give medical education, we have to give them enough practical experience, and we have to simultaneously see they are skillful and ethical. This is why MCI, which started 1954, now in 2003, 2007, and 2011, talking about ethics. Before that, when I was medical student, postgraduate, I did 7 years of training at AIMS after my MBBS in Delhi. The question is that, do we need that time medical ethics? We never know. So because now the things have changed, there is no guidelines, you have to have ethics. So in medical education, we have the three things which is suffering. When you look at about, if you look at any evaluation by medical, we want good quality student, good quality teacher, and infrastructures. Most of the medical colleges, if you take 500 plus medical colleges, they do not have good infrastructure. 30 to 40% teaching jobs are vacant. We interviewed between 2012 and 2016 about 15,000 doctors for AIMS, 6 new AIMS, and we could not fill many of the professor posts. Here you look at it. MCI say for assistant professor, you don't require any publication. For associate professor, you require 3 publications. For professor, you require 5 or 6 publications. If that is taken as standard of a medical college, then you are not going to get good quality teachers for the international standard or national standard. More importantly, in 2015 and 2016, it's found that only 20% of medical graduate can make 50% mark. If you take one side engineering, AICT, other side MCI, and compile, 10% engineer and 20% doctors can be considered as the A double plus. That means they are good enough, having 50% mark in evaluation. That means we are producing doctors, in a large number of doctors, needing the requirement of the country, those who are not having infrastructure or good teaching staffs. So where it has gone wrong? We have created medical colleges where 30 to 40% teaching staff are vacant, and teachers student ratio is bad. More importantly, when you select teacher, we do not take quality teacher. That is where the AIMS, PGI and other institutes score, because we have very strict criteria for selecting teacher. To get an assistant professor post IIMS, if somebody has got 20, 30 publication. On the other hand, there are many state medical colleges where 10 publication one can. So the two things, we do not have enough medical college to produce doctor. Currently, we are taking 80,000 students, 16 lakhs appeared. But then large number of students go out on the other country because they don't get a scope. So we have not got enough medical colleges. Whatever medical colleges, they don't have infrastructure and teachers. So we are talking a very complex situation. It is, we need quality, we need skill, we want experience, and we want ethics, and we want research. I was research dean of AIMS for 2 years. I was postgraduate committee chairman of MCI from 2009, 10 and to 12, when Dr. Sorin, my friend, was the governor. The question we thought, if we do not give approval for MD or MS for medical college, we are doing injustice because we have sort of experts. But if you substandard or dilute the requirement, you are not good giving good quality education. So it is a very complex situation. You need, but you don't have the quality people. You do not have infrastructure, because an average medical college cost about 300 crores. The currently AIMS is evaluated at the cost of about 15 to 1600 crores. So when you are, my AIMS where I was working at AIMS Bhubaneswar, it was initially planned for 350 crores. At the end, by the it is completed, it is over 900 crores. So imagine a medical institution of 1,000 bed cost about 1,200 to 1,500 crores today. So it is a huge amount of money. More importantly, if you get equipment, there is no technician, there are no qualified nurses. Look at me, I am working after AIMS coming to a private organization. In Odisha, there is no BSc technology. Even you look at a costly equipment, then there is no person. So what you need, not only doctor, for good medical care, you require good nursing care, you got good technician, you got good equipment, you want experienced doctors and skillful technicians. So doctor and medical services is not only doctor itself, it's a combination of doctor, nurse, technician, equipment, infrastructure, teaching staff, everything. So when you are talking about medical education change between 50, 70 and 2000, we are more of the skill based and experience based in 50s, 60s and 70s. When we go for more specialization, we are become more theoretical oriented because our number of patients per the doctors become less. When you go to super special in 90s and 2000, we have not got enough infrastructure. Many places they have DNB, so medical education in super special lab can be MD, MS or DNB. And if you look at where the DNB is imparted, there could be only 2 faculty taking 5 students with less infrastructure. So medical education are tremendously handicapped due to lack of infrastructures, because it's very expensive, lack of technically qualified, good quality teachers, and also the question is that we have become more investigation oriented than that of experience. What Madam said, Dr. Rao said, when we were student, I joined MBBS 70. There was no equipment, nothing. When I came to AIMS in 75, there was no CT, there is no ultrasound, there is no PET scan, nothing. So it was all clinical medicine. Today, the clinical medicine has taken a back seat, and everything is American medicine, is over investigation. It's a investigated medicine. People over investigate and send the report on WhatsApp and want they should get a treatment on telephone. So I think it requires a very big change. I am sure this new National Medical Council will look into that with Dr. Paul. He's a very brilliant student. And we will have a combination of good quality doctor, skillful doctor, holistic approach doctor and sympathetic, ethical, and more clinically oriented doctor. If you can produce more clinically oriented, less investigating, more ethical and society oriented doctor, that is what the society want. We don't want robotic doctors. We do not
Sure.
practice American medicine. We have to have more human. That is where the universal human value of UGC, AICT has a tremendous importance, because we are for the society, doctors are for the public, and the doctor want ethical, skillful. They don't know how many gold medals you have, but they don't know that how sincere and honest in your treatment method. Do you follow unethical practice? Do you over investigate? Do you write too many medicine for a small disease? These are very severe questions, lot of questions. So if I say somebody come to me at 70 years, he will be taking 10 medicine. If he comes at 80 years, he'll take 15 medicine. So anybody comes to my clinic, I ask how many medicine you are taking. I immediately cut down 50% medicine. I say you don't require three antibiotics, four B complex, or three anti-hyper. If I can manage with one anti-hypertensive, I don't have to three medicine for blood pressure or diabetes. So over investigation, over medication, unethical practice should go, because we have to have good human value inculcated in medical education. If that much can do, we can have more human doctor than robotic doctors. Thank you.
Thanks for sharing your views, Dr. Mahapatra, and thanks for elaborating all the changes that have been there for in last more than 50 years. And then what all challenges that have overcome. Probably, if time permits, I'll again come back to you to understand some solutions for all the problems that we are facing because of that. So, coming to Dr. Raisuddin, and as Dr. Mohapatra mentioned, the challenges faced during the COVID times, and uh, all three of your institutions have been at the forefront of fighting this battle with COVID-19. So, sir, with respect to the lack of infrastructure, as Dr. Mahapatra mentioned, and also the challenges which we have faced in recent times, where campuses are closed and classes going digital suddenly, and then institutions were made to make lots of changes which were totally unanticipated. So, how do you think this COVID-19 has impacted the education, medical education per se, and and has it been a boom as well? Because it has suddenly forced lots of institutions, made lots of changes, and introduced lots of technology as well. So, your views, Dr. Raisuddin.
Yes, yeah, thank you, Sachin and QS team. As I must thank you that you are bringing time to time people from different educational and technical or medical the streams, and providing and also launching for last few years a quality initiative in education. No doubt, all forms of our human activities have been affected because of this COVID pandemic, and not only education, even any profession has been badly affected. And all of a sudden, extraordinary situation has been created. Medical education, as you know, which is evidence based or clinical experience based, and also as our honorable panel members mentioned, it is a diagnostic, and lots of integration is there. So all activities are affected, but anyhow these and also there was a huge challenge to the medical education and also medical practitioners to cope with this kind of situation, because ultimately, even if we take any country's example, we see in western countries and in our country also, ICMR is in forefront. So medical education was there also to supplement the initiatives of the government, and they were also in the forefront, in fact, of this COVID fight. As far as medical education is concerned, no doubt it was possible to conduct classes online, to impart theory education, theory classes. But at the same time, you know that this is a evidence-based education system. Requirement is there. Pedagogy is like that. That is, students and these medical graduate have to observe uh, in person. And also they have to attend the outpatient and inpatients for their proper training. So many technological solutions are there, no doubt, for coping this. You, as far as I think my learned panel members must be also familiar that there is immersive learning and simulation kind of learning. By that, in fact, in our university in nursing faculty, nursing school, we have a very well developed center for nursing skill training using simulated models for all kinds of nursing practices or nursing training, which is to be given, even showing to students that how delivery is conducted, how patient is injected. We have bought huge number of equipment from Singapore, and we have opened skill laboratory there. I think using those technology, I think this kind of situation, challenging situation, can be fought with technology. Now online classes is with the help of technology. Similarly, for training of the students, practical training of the students, clinical training to some extent, and also giving them experience, we have to adopt. I think the medical education system has to adopt practices of immersion learning and simulated learning. To some extent, it can solve or it can provide the solution or alternatives. And this is one of the aspects which I wanted to highlight, that the technology only will provide a solution for this kind of challenging situations, and which is faced by every human being and every aspect. And no doubt, that Dr. Mohapatra mentioned, and my other colleague also mentioned, that there is a paradigm shift in medical education at the university level as well as at the policy level also. Very recently, government has formulated the new body in place of MCI, which will be looking. And we have to also, the medical education professionals have also to adopt new kind of this technology which I mentioned, like for immersive learning, simulation in learning. By that, some kind of uh, training can be provided, and these are accepted nowadays worldwide. That practices which are being followed, and they are no doubt technology driven. So we have to be technology driven. One important aspect that Dr. Batra mentioned, I would just like applaud him for bringing out the issues of ethics and also quality of the faculty. Quality faculty is only faculty are nothing but they are our own students gaining status of faculty. So how we produce, so quality is no doubt of the students will finally reflect into the quality of faculty, because today's student will become faculty after few years. So for that we have to look. We always say that faculty is not good, and they are not too quality is not good. They are not competitive. They are not having research intent. They are not having kind of the require kind of that quality, or require kind of profile rather. So that is only on us, that what kind of students we produce, they will finally become the this our future teachers. So we have to concentrate first on the students, what kind of training, new technology. And students are they are young, they need rather they are more adaptive to the technology. So we have to provide them those solutions. Maybe I am not in their generation, but we have to understand that what today's generation, our students, our even children, they keep on changing their mobile phone every 6 months because of the new version, new kind of technology has emerged. So they want to adapt. So in every aspect of their including teaching also, including learning also, they want to adopt new technology. They want to see that my institution, my teacher is technology ready. So the teachers have also challenging role that to meet the expectations of Gen X kind of students. So that is what I want to add. Maybe if you, in next phase of our discussion, I will talk about our Jamia University experience and and also research aspect. No doubt, if Sachin permit me, I will just highlight that yes, research is very important. In fact, even ranking by QS and ranking by time higher education, they give lots of weightage to the research components in the all education stream. Maybe it is pharmacy, maybe it is nursing, maybe it is biology, or in medicine also. And they also like to see that what kind of publications are made by medicine faculty. On basis of that, they rank. And very recently, this Times Higher Education ranking has come in clinical and health, and QS has also been releasing subject-wise ranking of the institutions of Indian institution, and also so this ranking, and no doubt many people may not be liking it, but also at least it is generating some kind of consciousness among the education providers that they have to meet the international standards at least, and they have to be competitive. So competition also comes to research. Generally, many a time we medical professions in we, because we are unique institution in that we have the modern medicine education college also, that is MBBS and MCI recognized college since 2011. And also we have very old Medical College for about more than 40 or more than 40 years old, established by the family. And then we have pharmacy, so we have nursing. So our focus is like Shastra Institute also focus in medical education. So we, at least at our campus, we have lots of this kind of collaboration going between medical and biology, pharmacy, nursing, physiotherapy people, and lots of research projects are coming jointly, and projects are leading to publications that is adding to our ranking. So I must say that yes, some research inputs and research orientation also has to be provided to the faculty first, and then to the students also in any form. So maybe in later course of our discussion, I will talk further if Sachin will have any questions. Thank you very much, sir.
Sure. Thank you, Dr. Raisuddin, for your input and your very specific input on the role of rankings and ratings, and also how research is also being supported in a way by that. So, moving to Dr. Rao, and ma'am, as you also had mentioned that research has become extremely important now, and all the institutions need to focus on that particular aspect. And now NEP is as I understand, all of you come from multidisciplinary institutions, but there are lots of standalone medical colleges as well. So when we talk about research, and that too in a multidisciplinary setup, whereas even multiple departments, different domains can collaborate and can actually work on solving some real world problems. They so instead of working on the part of a problem, they can actually approach it as a whole. So what are your views on it, ma'am? As NEP is also going to push that particular aspect, and lots of institutions have also picked it up already, and they are working on that.
Yeah, thank you, Sachin, for bringing that question in for discussion, because I think NEP has explicitly brought out some very broad principles, and that is likely to serve as a good framework and guidance for further progress of institutes of higher learning and higher education institutes. I know this multidisciplinary and comprehensive teaching and training of students, it's not something which is unknown. It's been there all the time, but the kind of framework which NEP proposes to come out with indicates that this is going to be well defined. It's going to come in as a project which is designed for outcomes which are also created and spelled out. There is a good scope for multidisciplinary, provided we all understand that we have to understand the broad principles of NEP. There's no escaping from that. Neither there is a reason to panic because we may not be able to follow exactly what is said, but we need to judiciously extrapolate the same principle in medical education as well. When we say multidisciplinary, we do understand multidisciplinary at different levels and in different sectors. We already have it multidisciplinary for the undergrad training to a certain extent, and to an even bigger extent for the postgraduate training. As far as the different specialities are concerned in the learning of the medical students. If we refer to multidisciplinary at different alternate medicines which are in vogue and which is practiced as integrated medicine in certain centers, that kind of multidisciplinary training, I think, will be useful, but the outcomes clearly depend on the design. I am not someone who is very comfortable to bring in all the alternate medicine and give tidbits of that in the medical education. Because I firmly believe that if there's some ability to practice a particular type of medicine, allopathy versus homeopathy versus the others, I think the prerequisite is a good, sound knowledge if the outcome has to be quality centric and patient centric. So I would prefer that instead of introducing tidbits of all specialities and cramming the medical graduate with half knowledge of a lot of issues, it would be even better at the end of the primary degree in medical training, like the MBBS, then offering them specialized training on lines of a postgraduate training like MD medicine, MS surgery, etc. You can have MD Ayurveda, MD Unani, or something like that. That would give them the advantage of good training, and they will develop the ability and use their discretion as to which patient requires a combination,
और जेटा दोने
integrated or allopathic alone, or the alternate alone, depending on the suitability. Therefore, my personal, my personal opinion is that instead of cramming all this at an undergrad level, it could be offered as a specialization,
I can't कोई भी
as a specialization post MBBS that would serve the purpose much better. We should not be trying to bring in multidisciplinary for the sake of bringing in. There is another aspect of multidisciplinary. When I say multidisciplinary in another aspect of medical graduate system, I would rather refer as a team-based approach, wherein it's a doctor, a nurse, a pharmacy, or a dental, a physiotherapist, and all these specialties working as a team, I think can bring out more fruitful outcomes when it comes to a comprehensive care for the patient, starting from preventive, reaching far up to rehabilitative treatment. So, multidisciplinary, as we understand, should have its different facets of multidisciplinary training. And I firmly believe that for a medical undergraduate, it's the team of the entire healthcare team, where it is doctor, nurse, pharmacist, etc., working together as against the current practice of all these healthcare workers work in silos. The pharmacist is in his own field. The nurses are doing their own job inside. So a better team effort is going to be far more effective when you talk of multi. So when we understand multidisciplinary approach as put up by NEP, my personal feeling is that the medical fraternity should sit down and deliberate what aspect of multidisciplinary we would like to adopt in the medical education system or training of medical graduates for better outcomes. That's my thing about the NEP. This other point which NEP makes is, which I think is very valuable, and it should come out a little earlier, is that they are talking of graded autonomy even for standalone medical colleges. They're graded autonomy based on research and teaching abilities. That's going to go a long way because that's going to promote innovation. Because the moment we are autonomous, we have a little more freedom to innovate, and I'm referring to innovation in medical teaching methodologies. I see in my own institute that there is a lot of talent when it comes to teaching methodology. Today, we are looking at the most effective teaching methodology. So, which is why that's going to be important. And as Sir was already mentioning, the role of rating agencies, let me add another, my 2 cents into it. The rating agencies help all institutes to keep themselves on their toes. It automatically creates a kind of accountability. We are not getting into this field of rating, getting rated just for the mere look of it. I am so and so in the national rating. But it makes people get more organized in the delivery of the training processes. They're more organized when it comes to policies in the institute. And of course, a high order of accountability, which I personally think goes a long way when you are establishing quality education across the country and across all institutes, especially if we want to compete, whereas as far as quality is concerned, on a global platform. So that's what I would like to say. That is the boon of NEP. We have to take it in our stride, look at it very carefully, go into the depth of understanding what exactly they mean, try our best to extrapolate it to our aspect of medical training. And I think the medical fraternity has to be sitting down and debating as to how best we can fulfill the principles laid down by NEP. And I think it's going to be good in terms of promoting quality training in the medical colleges across the country. Thank you. This is what I would like to say. I'm curious to hear what my other panelists say.
ଆମେ ତ ପଇସା ଖର୍ଚ୍ଚ କରିବା ଆଣି ଗୋଟେ 5,000 ଟଙ୍କାର ଗୋଟେ ଆଣିକି ଭଲ କାମ କରୁଛୁ କାମ କରୁନି ସିଷ୍ଟମ କାମ କରୁନି ସେଇଥିପାଇଁ କହୁଛି
For Dr. Raisuddin. So, sir, with respect to NEP and multidisciplinary education, may I try to understand your views as you are already a multidisciplinary university known as a research institution and already an institutions of eminence. So how do you look at this, and what do you think will be the impact on medical education when it comes to the suggestions in NEP and the policies suggested in that? Hope you could hear my question. There is some background noise, I believe.
Yeah, as yeah, I can hear. Yes, let me speak, Sachin. As Dr. Rao has rightly pointed out, that any kind of integration or any kind of this multidisciplinary approach has not to be in an artificial form. That it should not be imposed or it not be just superimposed on somebody's kind of. So it has to be inbuilt integrative approach. For example, there is it is not anywhere mentioned, but any medical education is one of the highly multidisciplinary profession or education system where it itself has lots of specialties. MBBS student or undergraduate students goes a lot of multidisciplinary education already. So, but I think in an NEP, new education policy, which is still in the adaptative phase, is still educationists like me and madam and other vice chancellor are still studying it, knowing its tidbits and implementation aspects, still not very delineated. And even at government level also, discussion is going on, debate is going on, some kind of implementation roadmap is being prepared. So integration is always welcome. And doctors and even those who are in the biology field or in the pharmacy field or in the other field, they have already integrated a bit. And this new impetus which is given nowadays to Ayurveda, yoga, and all those disciplines. Very recently, in Safdarjung Hospital in New Delhi, they have opened already Ayurveda OPD was there. Recently, they have opened this Unani OPD. So at least systems are now welcoming each other and opening their arm to embrace the other system. And I think in this our country especially is one of the unique country where there is a Ayush ministry, which is Ayurveda, Unani, Siddha, and homeopathy also they have integrated. In many countries, people even don't integrate homeopathy with the medicinal system. Even in Britain system, but in UK, they sometime a large majority of people do not consider is a medical practice. They sometimes compare it with placebo. So in our country, the integration is there. As well as new education policy is concerned, the other in beside new education policy in our country, we have lots of regulatory agencies like MCI has been replaced by another agency. There is Pharmacy Council of India. There is Nursing Council of India. There, so all these councils have also to be brought on one platform, and they have to sometime also uh, told and also to be directed that they have to also adopt multidisciplinary approach. Sometimes it is very watertight kind of thing. Like in pharmacy, I because our university is having good pharmacy college and pharmacy school rather. So their PCI are very strict. They don't even allow non-pharmacy teacher to teach in their faculty. Sometimes they don't even give recognition to the non-pharmacist as a teacher, and they don't even count when this counting is done for the giving recognition. So these regulatory agencies have also to be directed to be open. They have to be also they have to look into multidisciplinary approach. And all Professor Rao, Professor Mohapatra might have seen that in Western education system, you will find that the medical college or medical university is headed by some technical person. Engineer can also be vice chancellor of the medical university. So we are not so open. At one point, we are very much don't allow other people to come in their profession, and at the same time, we want that it should be integration. So at the policy level, at the regulatory level, lot has to be done. Except this policy has come, and we are discussing it. Only I don't know what will be and how it will be adopted. It will take a long time. You remember that in Delhi University, once they launched 4-year graduate program, undergraduate program, and in on the pattern of France and European countries and Western countries, and it was opposed by the teachers, and finally it was wrapped up. So how? And sometime government also talks about shorter duration for medical graduates. Lots of policy clarity is also, I think, to be done. Then only we can think of integration as we see in other places. And I must say that in any country, any advanced country you go, and Nobel Prize are won by most of the time from the medical colleges or medical faculty, and the colleges and universities are known for the medical. Harvard Medical School, you can call Oxford in Japan and other places, and cutting edge research is being done at the medical education institutions. That is not in our country. If we count on fingers, very few medical colleges in our country, maybe 10% of the all medical college are internationally recognized as a cutting edge research centers, which is against the trend in the Western countries. Only medical, it can be any Texas medical, and every medical university is there. With the medical university, we when we assume in our country, it is medical sometime just for award of the degree. I'm very sorry to say, but not for the research. Still, we count if we talk about medical oriented institutions, only few, all mostly centered in Delhi. We call AIMS, Safdarjung, Maulana Azad Medical College, Reddy, Safdarjung. Then little bit we go about Manipal and these scattered places like Shastra and Madam's Institute. And so if we count, we will find that out of so many medical colleges, 10% of the medical colleges are research intensive. And many a time the research is also driven by the allied faculty or allied disciplines. This integration has to be not artificial, as Madam is pointing out. Integrated integration has to be from within. Then only it will be. Otherwise, it will be like requirement. MBBS graduate has to do some Unani course, some Ayurveda course. Some places it has been mandated that they have to opt one 2 credit course. So student will do 2 credit just to get pass, and they will forget about those principles and practices of those systems. Just for getting a degree, they will come and get integrated for a very short duration. After examination, they will disintegrate. So that has to be ensured. So that is why my take. And as far as any other question about artificial intelligence, I think Sachin wanted to ask if anything you want to ask, please ask.
Sure. So thanks for your views, Dr. Raisuddin, and very interesting inputs about NEP and how things are being done in other more advanced countries and the colleges across the world. So, and my next question, and I will try to circulate it to everyone, and this will be the last question as well. So, so be it the research that is being done at the institutions, or be it the delivery of education, eventually it has to be done by the people, the faculty members or the students. So I will try to understand, and first I'll go to Dr. Mahapatra. And as sir, you mentioned that getting quality faculty members is a challenge, and this is a concern as well. So from your perspective, what exactly institutions can do, or probably you can share with your experience as how you are doing it at your institute, so that we can have research oriented faculty members, and we can generate better kind of research from these institutions, and in turn can probably improve the quality of education that is being done as well. So your views on this, Dr. Mahapatra, and I would also request you to keep your views brief, to maximum 3-4 minutes if possible.
Thank you very much. See, you are talking about faculty quality. So we have to have faculty development program. If you look at AIMS, in 1982, we sent the people abroad for the faculty development. Then every institute, MCI said there should be faculty development program and medical education hubs in medical college. So in new education policy, when you trace about quality of education, in quality of education, the two important parameters: quality of the student, quality of the teacher, and infrastructure. So there you have to have time to time medical teachers to be updated so that they are not lagging behind in the old knowledge. Medical knowledge is very rapidly expanding. That is the reason National Teacher Education Program started in Pondicherry. In AIMS, we say CMET started 1982, centralized medical education training. Every 2 weeks, there is some medical education training for the teachers of the middle order, either assistant or associate professor or additional professor. So you have to time teach the student and to teach the teachers so that they get updated. Coming to the skill development, Dr. Ashuddin was telling about skill labs. It is not only for nursing, skill labs are necessary. In deficiency of teachers, we all require simulation. Most of the advanced university has operation simulation and education by simulation. So we have to have quite a lot of technology. That is why in Sanjay Gandhi, where I was director, we started spending one crore only for the IT, that is for that is telemedicine. That is 1996. But when I was director 2005, we had the hubs for the data center and skill development labs, and we spent 50 crores from government of UP to develop content development center where the people come very specialty and get the hands-on simulation and IT professional. So IT has to, because we have less skilled manpower, we can partly do away with technical skill by IT professional. Now coming to holistic approach, where we have to integrate various part of medicine to our each to each other, where we talk about integration. That is why in 2005, Government of India started Ayush. In Ayush, all the new M's have got Ayush. But what is happening? Our medical faculties are not allowing yoga, Ayurvedic or homeopathy to work properly. So integration is a mindset. If you look at medical science, Banaras, BHU, Dr. Udupa was a trained Ayurvedic doctor. He did MBBS, then he did MS and FRCS, and he became the director of medical education of Banaras Hindu University in late 60s. So medical is not a patient when he comes, he is not interested. We are giving allopathic medicine, Ayurvedic medicine, or homeopathic medicine. He wants to get cure of his diseases and suffering. So we have to integrate all the medicine what we are practicing. Here the number comes. We have increased the number of medical graduates from 25,000 about 15 years back to 80,000. But if you look at the number of homeopathic and Ayurvedic colleges, they are taking 10,000 homeopathic students all over India in last 30 years. They have not increased. They have not introduced postgraduate courses in homeopathic or Ayurvedic. Ayurvedic medical college do not have teacher because there the professor is equivalent to associate professor in medical college. I have gone to large number of medical college, homeopathic college, Ayurvedic college. I see they are being looked down upon by the government. The man who looks after the Odisha homeopathy Ayurvedic is a deputy secretary. The man who looks after the medical sciences is a principal secretary. So there is a mindset, there is a thinking process difference that our homeopathic and Ayurvedic are not as good as allopathic. It's not true. To get away that concept of doctors are superior, MBBS doctor, they started ICU. They wanted to integrate in all new M's. Now there are 22 new M's, and one of the building is about 50 bedded Ayush, which is 2 Ayurvedic doctor, 2 homeopathic doctor, 5 pharmacists, their materia medica, everything, so that you have parallel and you have yoga teachers and yoga training. I took homeopathic, Ayurvedic and yoga teacher and AIMS Bhubaneswar. So our aim is that we should give a holistic medicine which could be an integration of partly allopathic, partly Ayurvedic, partly naturopathy, because that is what Mahatma Gandhi said 1940. The people of India will not be able to pay out-of-pocket expenditure when the modern medicine comes. In 1940, National Institute of Naturopathy started at Pune, and Dr. Mehta was the director. So Gandhiji said that I want people to be cured in natural process by yoga, pranayam, asana, physiotherapy. So this is a part. If I have to treat I am a neurosurgeon, I do a brain tumor, person become paralyzed, he requires physiotherapy. It doesn't mean that it is not a medical practice. He may require oil therapy. He may require heat therapy. So it is naturopathy, allopathic medicine, Ayurveda. If you know that pandemic, the government of Ayush and government of India has given that arsenical alba. Arsenical alba is a medicine which is government of India propagating to improve the immune status. And it is distributed all homeopathic, but our medical doctors will not accept it. The number of medical doctors died of pandemic like COVID is more than 15,000 in the world. 5 of my batchmates have died of COVID. But if you tell them take arsenic alba, they won't take it because the mindset has changed. So it is a slow process. Over 50 years, we have got rigid compartment, homeopathy, Ayurvedic, and allopathy. Somewhere the boundary has to go, and we have to practice a holistic medicine. So new education policy, which gives stress on quality education, skill development, integration, holistic approach, yoga, stable mind, and lose the boundaries so that it is not strict allopathy or strict homeopathy. And then you have to go too much of importance to IT, because we know medical education has to be a IT oriented, because we have to have telemedicine. Now, I operate huge number of patients at AIMS Delhi, those who belong to Odisha, but I give them consultation on telemedicine platform at AIMS. They did not come all for follow-up. So you can have follow-up consultation, and many things can be radiology. What is happening today? The state medical colleges have radiologists, and district headquarters do not have radiologists. The radiology does district headquarters, the MRI and CT. It is transmitted through the PAC system and internet, and you give a radiation report at Cuttack or Bhubaneswar. The question is that we are practicing the digital technology in medicine, but more and more digital technology will come because we lack manpower, infrastructures, and skilled personnel. So new education policy stress on quality education, skill education, innovation, research, and holistic approach. If we can integrate all these, even though new education policy do not include pharmacy and medicine and nursing, it is the basic tenet of the education is same: quality education, skill education, innovation, research, technology, and holistic approach. So that is, I think, very much applicable to medical and nursing education. And madam was telling, sir was telling that there is a lot of simulation in nursing teaching. That is the nursing. If you go look at the nursing council and there's curriculum, I was developing nursing curriculum for 6 new AIMS in 2012. So we knew that lot of simulation has to come, because if a nurse has to know how to deliver a child, how to give the breastfeeding, you cannot practical. So many things has to come. So technology has to come, medical, nursing, and pharmacy education. Then only we can cope with the demand, and quality also will maintain. And regarding research, let me have 1 minute if you have time. The Stanford University has told 2% top scientists of the world. India has now 1100 scientists named as 2% scientists of the world. If you look at the medical scientists, out of 1100, not more than 150. When I look at AIMS in last 70 years, there are 15 people. PGI Chandigarh from 1960 to 8 people. Vellore has 6 people, 3 people for KEM, and KGMO 2. So if you look at the total medical personnel, which are include 2% of quality medical from the world, it doesn't come more than 100, 150. So the question we know, where do you stand on the quality scientific paper research? What Dr. Rasuddin telling that the research has not got a price. Today the ICMR doesn't give money. There is no fund for the research. There is no intramural grant. There is no extramural grant in 90% of universities. Even in my university today, we are talking about research. We say there should be some seed money for the young faculty. All young faculty cannot have extra. There is too much of competition. The funding agency, DST, CSIR, INSA, biotechnology, and ICMR are dried of money of research. There is hardly any money. So the question, how do research? It is very nice to tell research, but when you come to the real money spent for research, total expenditure of India's health was less than 1%. By very much difficulty, it has come to 3%, out of which 1% by government and 2.5% by private partners. So with 1% budget of health, what type of research we are talking about? So research is not a nothing which come out of without money. You have to spend money so that you get outcome, right? So that for research, quality research, you require quality lab. Let me tell one thing. When the pandemic started, Odisha did not have a lab which did virology. All the sample was going to National Institute of Virology. How quickly? We have got now 16 labs doing molecular diagnostic RT-PCR, and about 50,000 tests for COVID done, RT-PCR done, and rapid test done. So we have adopted. Then the government has started spending money for BLS3 labs. See, it is not all Delhi, Bombay, or Bangalore. There are state medical colleges. There are smaller cities where you cannot have molecular diagnostic tests. It is only pandemic where large number of centers. If you would have seen March, would have seen India did not have 10 molecular labs. Today we are telling more than 200 molecular labs. So we have done it. We have spent money. So we cannot have money and yet talk about quality. Quality doesn't come without infrastructure. Quality doesn't come out skilled manpower, technical manpower. How many technicians are trained BSc molecular medicine? How many how many university giving molecular medicine PhD? I know it. I talk to the biotechnology professor. Can you give 2 technicians molecular medicine? Say, I don't have any. You can take a postdoc. So we don't have quality manpower, believe or not. We do not have BSc operation technology. Don't have a MSc radio sciences, radiological sciences. We do not have MSc technology radiotherapy. So medical science, quality education, quality care is a multiple package where you require a combination of skilled personnel. Thank you very much.
Can you also give your inputs very briefly on how the faculty members can be prepared when it comes to all the challenges or changes which are coming in future, and how they can be prepared for doing that
Faculty,
research that government is also talking,
exactly.
and that
In
is needed.
AIMS or new AIMS, we don't fill out the professor because we do not come under MCI. So we can start MBBS with an associate professor, leaving the faculty professor post vacant. Because if you fill a professor post at 40 years, who is only not suitable for that post, I would rather see that post is vacant. So your selection faculty should be very top. Recently, there is a Hyderabad faculty selection for AIMS. For 180 posts, there are 12,000 applications. The professor post, my dean who was at AIMS Bhubaneswar, he knew how to be strict to have a quality teacher. It is rather to have a 5 years or 3 years vacant post than filling up a substandard person or who is not suiting that post, because once somebody comes as a professor at 40 years and doesn't have the requisite experience or research, you will not be able to throw him out because his retirement is 65. So question is that your selection of faculty is very important. Then when you selection faculty, make it mixture of PhDs and also the doctors. Because when you are taking microbiology, pathology, immunology, biochemistry, we medical people try to help medical doctors. We do not. But this is not the case at AIMS. We would like the department of 10 should have 3 people PhD postdoc so that they carry on the basic research. Because the clinician will always say that I am overworked, I work morning to evening seeing patient. That is the case. So your selection faculty should be quality and a mixture of people. Do not fill up quickly the post because you need it. What MCI need, that unless you have professor, you can start. If you have 50 departments, 5 departments do not have professor, they de-recognize you. They would rather have a substandard professor carry on than leaving the post vacant. This we don't believe at AIMS. PGI, AIMS, NIMANS, Pondicherry, they do not come in the ambit of the many bogus rules of MCI. I was postgraduate committee chairman. I objected, but the rule cannot be changed unless it's passed by parliament. If the rule say a department has to be only headed by a professor, nothing else, you cannot start MBBS without all the professor filled up the department. This should not be. A assistant professor can be good quality than a professor and HOD. So selection teacher. Then the question is that many medical teachers think once I have joined, I have nothing to do, I have become professor. So there should be professional development course. If you see the army, as a major, they go for 1 year training. When they become colonel or brigadier, they go to Lucknow for 6 months training. That is intermediate training. So even the armed forces have time to time upgradation and training. We in medical also should have every 5 years review your performance, your credibility, your research. Nothing happens. In AIMS, I spent as a faculty 38 years. I had 7 interviews. I joined as interview as postgraduate. I joined a senior resident of general surgery, senior resident research, 3 interview for a 7-year residency. Assistant professor, associate professor, additional professor, professor, and director. So I had 7 or 8 interviews. Nothing came lightly. But in MCI guided rules, you say if you are 5 year assistant professor, you become associate professor. You have 5 years associate professor, you become professor. It doesn't matter if you have published 6 papers. When you talk about quality, with 6 paper you cannot get AIMS as a senior resident. You cannot get AIMS with 6 paper assistant professor. When we interview for 14,000 candidates from 6 AIMS: Bhubaneswar, Patna, Bhopal, Jodhpur, and Rishikesh. We saw the assistant professor has more quality publication than the professor. So professor, those are 40 or 50 years old, those days publication was not a priority. Today the competition. So you have to keep yourself emotionally stable. See that I do not fill up a post because I risk myself being de-recognized. These are the risks what MCI give us. MCI say without a professor, your medical college will be de-recognized. That's not good. Those bogus law has to go. A good assistant professor, associate professor may be better than a professor who is not good. So, and you should evaluate a professor. If the performance is not good, he should be fired. I don't mind somebody fired. He may go to court, but then you cannot have both way. You keep substandard people and then talk of quality. So it is like
Sure.
two sides of a coin. So good quality teacher, time to time accreditation their performance every 5 years. If they are getting promoted, do an interview, let their peer review. Their performance should be on the research and academic and also publications. We are evaluated at AIMS for our teaching, for our research, for our publications. The AIMS spend about 10 crores rupees for giving award to good faculty, 10 to 15 lakhs for the best paper every year for basic science, and 10 to 15 lakhs every year for so we have one award each for one faculty. So you have to give incentive to faculty so that they are motivated for the research. So
Sure.
research has been motivated. Thank you very
Sure.
much.
Thanks for your very elaborate inputs on different aspects of faculty recruitment and then the assessment process overall. So, Dr. Rao, I would take your inputs and I would request you to be very brief in the interest of time, and then I'll come to Dr. Raisuddin with the last question that is from the audience. So, this one is for Dr. Rao. Ma'am, please share your experience with us when it comes to faculty development and faculty preparedness for research and all the new technologies and new changes which are happening out there in the medical education.
Yeah, thank you, Sachin. But my experiences are a little different from Professor Mahapatra's because he held different positions and they were much more powerful positions which he held. And then let me also make a thing that I completely second what he said about the medical education unit or the department, which every institute has. And I can also boast of one medical education unit in our institute, which is doing a very good job, although my expectations keep going higher and higher. And we have very good discussions with all the members who are qualified and trained. We have even female graduates and they undergo regular training programs at regional offices and they conduct faculty development programs as well. We also have our policies as to who needs the faculty development program on a priority. We have a good mix of the basic and the clinical faculties where we are recruiting as a good mix so that it's not that we have faculty development only for one sector. So that said about the updates, but we don't have the luxury of leaving a post vacant, as Professor Mahapatra was saying, because we are still under the mercy of the regulatory bodies. And we cannot escape from that. And therefore, sometimes, whether I like it or not, I have to be having people who may not be fulfilling 100% of the times the kind of expectations we have. So even if it is a well-intentioned policy, sometimes we are at the mercy of regulatory authorities. I must say that, and which is why there is some amount of handicap for these kind of medical colleges. And we do have a little difficulty in that area. I completely agree with him that it's not the designation alone, and we have certain very good young talent. We have also presently identified. I'm lucky that I do have young talent, and I've taken picked up a lot of points from Professor Mahapatra as to retain their motivation and promptly acknowledge their competence, etc. So on the front of faculty development, I think I am in line with what he says. Only thing is, I sometimes envy the luxury he had, and we don't have that luxury of keeping the posts vacant. But let me see, I think with the new NEP, as I said, that gradual autonomy might help in this aspect, is what I feel. And I must say that we are into aggressively a lot of efforts to keep the faculty upgraded. And I'm trying our best to motivate them for research and see if we can fall in line with what Professor Resudin is saying. I understand and acknowledge research is very critical, but it's not everybody's cup of tea. I agree with that also. There are some good clinicians and we are encouraging them to give the good inputs on clinical aspects. So research also we have already assessed. We are trying to look at the research aptitude. We are trying to inculcate this aptitude even at the undergrad level. We are trying to get them familiar with the research methodologies so that we are empowering them into getting to research right from now because we do believe in the principle of catch them young. So that said, we are already into this where the undergrads are being trained. I do have a division of research and patents which is looking into all these aspects. We are trying to keep it as a one stop so that all the faculty knows that go through the DRP and it's going to help them. Of course, we are yet to settle on a lot of policies on seed money, incentives, etc. But we are doing it step by step. And I do see some kind of a light at the end of the tunnel in this because this is a difficult area. No doubt this is a difficult area. No doubt this is something which is required. But I am happy to say that we are working aggressively in this area. And we are also greatly into simulation, as he said. Ours is one of the very well established simulation lab. We have a skill development lab. We have a cadaver workshop center, which is doing great work and great clinical workshops. And we're using that for faculty development in-house and as well as delegates who come from there. So that said, I think we are in tune with what my co-panelists have been saying regarding research, skill development, faculty updates. And that said, thank you. I think that's all I can say.
Thanks for your inputs, Dr. Rao. And the last question is for Dr. Raisuddin. And sir, I request you to be as brief as possible. The question is from one of the viewer, Aishwarya. And the question is, and since you talked about there being a huge gap between international medical education institutions and the educational institutions in India, the question is if we could be bringing one best international practice in India's medical education, what would it be?
I would like to just say that there is our institutions, like many medical educational institutes, are also very well known worldwide. And I don't like to say that my intention was not to demean or to belittle our own education institutions. They are one of the best institutions. In fact, the product which is made by these institutions, when they go abroad, they are stars. So, what I would like to say that once one in the beginning itself, these two types of distinction were made: investigative and clinical based. So, I think we have to go to the, I fully agree, evidence and clinical based medical practices instead of going to diagnostics and investigative based, where we must depend on the machines and their outcome. So, clinical based medical practices should be encouraged. And I think Dr. Mahapatra and Dr. Rao have already highlighted that that is the core, and that is, in fact, the best way to educate our undergraduate. One more thing, sir, with Sachin, with your permission, I would like to say that we Indians are very fancy of going abroad and spending our time for 3 months or 6 months here and there. In mostly go to European, Japanese, Korean, or American institutions. I have I want that people like Mohapatra and these people. Why can't our own faculty within India they move? They should go like All India Institute of Medical Sciences, Sanjay Gandhi Postgraduate Institute of Medical Sciences, PGI, Chandigarh, and KGMC, Lucknow, Vellore, and these all. Why don't our own faculty go to these institutes to spend 6 months, one semester, and that kind of provision should be introduced, kind of loan. It can be very easily done by young at the young faculty level. Sometime if you become professor, you can't go, you have family responsibility, also you are head of the department, dean. At least our young medical faculty should be exposed to the best medical practices uh, performed at All India Medical Sciences or star-rated institutions, specialized institutes like ILBC, Institute of Liver and Brain Sciences here and there. Lots of good word quality medical faculty is there in our country. Medical schools are there. I don't want to say that we are anyway behind them. The only thing is that our system is such, and we have a lot of social and political pressures and pulls and pushes. So that is a different story. But at least exchange should be conducted. Why we like to send, and I like to prefer to go to Western country to spend my time under INSA fellowship, under this fellowship, under MCI, ICMR program, this and there. Why we create a provision where at least 5 to 3% faculty spend time on the exchange basis, on the this loan basis, kind of loan, faculty loan. So best of the professor can go in 6 month or for one semester, can teach at the other institution, and from there people come to your places. Amongst itself, they will learn the best practices being performed at other institutions. So maybe vice chancellors and two vice chancellors are there. They can initiate. I have always advocating this benchmarking of the within why not a comparison, not a competition. At least we accept that there are some good medical colleges, there are some not so good medical college, there are some medical colleges which are going to, we are trying to become good medical college, but those who are established track record, legacy, there we should develop that kind of exchange program of faculty within India. Why we go abroad? Why we send our faculty to other countries when the same kind of training is available within India? I know. If we talk in the sciences, then in Indian Institute of Sciences is one of the best institutions. Why we send somebody to go to MIT or Harvard or to Oxford and to other places once the similar kind of training and exposure is available within India? So we should explore those kind of avenues, and that is what I wanted to add. And it will not only create a opportunity for young faculty to learn, to see, to best practices, to develop its profile, to develop contact, also to develop collaborative research program, and to get funding opportunity, and to practice the same institution, same kind of practices when they return to their own parent institution. That is what I wanted to say. If any other expert member like to comment quickly. Yes, Dr. Mohapatra ji.
We don't do.
Sir, but
See,
I would
most of the
request you to,
other
but the only
one
request.
minute. See, if you see other very good medical universities, they give break in between the clinical, non-clinical. The student can go and do internship for 1 year. The what new education policy, they can have a break, go and see and come back. Coming to the people going abroad, when I was doing neurosurgery training from 79 to 81, I went to Vellore because we had a program at AIMS that all our students will go 15 days to Vellore, 15 days to KM, 15 days to Chitra Tirunal, and 15 days. They can choose 2 months or 1 month or 1.5 months by their own expenditure. So we had a program which even today we stand our resident, 6 year resident or 3 year, to go and see other places. So there is nothing wrong people exchanging in between our good institute. I went to Vellore in 1979. I spent 2 weeks, then I went to Nimans, I went to Sichitra, then I went to KM. So I saw 4 institutes in 2 months to see where do I stand at AIMS as compared to Vellore. So what Dr. Rashidin telling absolutely correct. Sometimes we become like Kupamanduka. We think what we are doing is the best. It's not true. We should see what is best, what is optimal, what is least, and what we are going to practice. All MBBS of AIMS are not going to stay as a faculty at AIMS. They have to obviously go to the small places. And when they go small, they become demoralized, depressed, and they say, I cannot work, commit suicide. Why, Doctor? 25,000 students are committing suicide. There are BTech, MTech, MBBS, PhD students. We have found out 1.6 lakh committing suicide, 20 to 25,000 are higher education people. It's very sad because we have not able to give them mental stability, telling no, you should expect as per your mindset, your education level, your capability. Everybody cannot be good enough. What madam was telling, everybody cannot do research. But if out of 100 faculty, 50 can do good research, that is good enough. Somebody is good in something. That is what new education policy say. You get best out of a student. See his capability, exploit that and innovate his ideas. Give him better opportunity. So that is what Dr. Rashidin telling. Give them opportunity to see other places. In India, it's at least. Thank you very much.
So thanks for your inputs, Dr. Mahapatra. And I think this was
Thank you.
an extremely enlightening session. We have gone into the details of lots of aspects, and uh, when we are having such an enthusiastic and experienced set of educationists between us, then we can actually go on for a very long time. But in the interest of time, we have to end it. It's been good 1.5 hours. And also for the audience, this roundtable was supposed to be moderated by my colleague Shubayu, but due to some unavoidable circumstances, he could not join. So I had to stop in and do the moderation part. But I believe it was a fantastic session, and as is evident from the feedback from the audience as well.
We
So
are
on
remain
behalf of the
engaged and curious
so on behalf of the
for
entire
at least
QSIG's
providing
team,
three brains are meeting. Thank you,
so
Sachin and QS, for
sure,
providing platform that at least we three will have met and discussed, shared our idea, and maybe we will continue meeting in
sure.
other platform in other way. And our university Jamia Ahmedabad is open for any kind of experience sharing. We are doing little bit good in pharmacy. Again, I don't want to say that it is a brand or something, but NRIF, we are number one. And recently in Times Higher Education also, we have come in QS subject ranking also. We are there. So we want to share our experience with anybody, any faculty
Sure,
member of these reputed institutions. If they want to come
sure,
to our university, spend time. And one more thing that we have also three industrial hub in our center. One is for vaccinology, established by Wellcome Trust, and one is Becton Dickinson Fax Academy, and Sun Pharmaceutical Limited has also established its clinical pharmacy unit in our medical college. So that way we are also having with industry very close collaboration, which can be seen and shared with other faculty members from these reputed institutions. And
sure.
I will be very much welcome. My role is collaboration and all that. So I will extend that. Thank you very much to
Sure.
all for this opportunity.
Sure, sir. And on behalf of the entire QSIG's team, I'd like to thank Dr. Medha Rao for taking out time and coming on this platform, and also Dr. A.K. Mohapatra and
Thank you
Dr.
very much.
Raisuddin, of course. So it was a fantastic session overall, and we look forward to seeing you again sometime. And also for the audience, while you are here, since it's being telecast live on YouTube as well. And if you have not subscribed to our channel, please do that, because we keep conducting such enlightening events from time to time, and you will keep getting notifications of them if you are subscribed to channel. So with this, we come to an end of this session, and once again, thank you very much for being part of this, and thanks a lot. Thank you.
Thank you, all of you. Thank you very much. It was a great
Thank you,
pleasure.
sir.
Great. Thank you, sir. Bye.
Thank you. Thank you. Thank you, sir. Thank you, madam.